this, we're taking 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 with a pinch of salt.
Dear colleagues, welcome to A Pinch of Salt, your ERA podcast. I'm George Kosmadakis, and today's discussion is dedicated to the intricate world of renal pathology. As specialists, we understand that renal pathology is not just about diagnosing conditions, but also about understanding the underlying mechanisms that drive them. From glomerular diseases to tubulointerstitial disorders, the nuances of each pathology can significantly impact our treatment strategies and patients' outcomes. In the current episode, we'll try to describe the methodology of analyzing a renal biopsy, the evolution of the techniques, the association of biopsy findings with an individualized treatment strategy, and the future evolutions. Our guest today is Professor Ingeborg Bajema from the Department of Pathology and Medical Biology, University of Groningen, Netherlands. Ingeborg, thank you very much for being with us today.
Thank you for inviting me. It's my pleasure.
So, Ingeborg, can you describe in a few minutes how do you work on a renal biopsy nowadays? What kind of treatment and what kind of gestion?
Yes, I certainly can. So I think that the most ideal workup of the renal biopsy is when the pathologist receives enough tissue and enough clinical information in order to do a good workup. And that is perhaps then one of the first things that I would like to mention in this video, which is probably seen by a lot of nephrologists in the field. Because all over the world nowadays, radiologists mostly take the kidney biopsy, which means that literally that the distance between the nephrologist and the patient and the biopsy becomes a little bit larger. And often the radiologist does not know about the question. And sometimes we get only a very small information form, and sometimes we don't get enough tissue. So coming back to the ideal situation, ideally, we would still like to receive 2 cores of kidney tissue that ideally both have enough glomeruli so that we can work on one piece for our paraffin sections and look at all the stainings that we use for kidney biopsies, which are a number of stainings, which enable us to see all of the lesions, and to use the other piece of tissue for both immunofluorescence or immunohistochemical stainings and for electron microscopy. Ideally, you would have enough tissue for each biopsy to reserve a very small portion for electron microscopy, because in the end, you never know for which biopsy you may need it, and eventually the electron microscopy may give you an important diagnosis that you cannot make if you don't have it. As for the immunofluorescence or the immunohistochemistry, ideally in a laboratory, staining should be performed for immunoglobulins, C3, C1q, and also for the light chains. And that is the ideal setting for the workup. So then, of course, we need a lot of clinical information in order to interpret and to look for differential diagnosis. And then in a laboratory, of course, all the tissue slides are made and they come to the pathologist today either still as glass slides or as scan slides, because I'm talking to you from my room in a hospital. You still see my microscope over here, but actually I only use that still for some additional tests. For instance, if I want to look at crystals or amyloid, but most of the pathology I see on my screen, like I'm talking to you now. I also see the biopsies in scan slides. And that, of course, is a recent development. And perhaps you want to know a little bit more about the recent developments, or is perhaps that your next question?
That's a perfect bridge to the next question. How have the renal pathology techniques changed during the last years? And concerning your answer, I would like to know when you talk about a sufficient number of glomeruli, how much is sufficient?
Yeah. Well, for some diseases, actually, one glomerulus is perhaps sufficient to make a broad diagnosis. I always say, okay, if I have one glomerulus and I see a lot of IgA in combination with C3 and none of the other stainings, then that would, of course, very much suggest IgA nephropathy. The same thing goes for a full house pattern in a patient with SLE, probably lupus nephritis. So one glomerulus can already reveal a lot of information. However, of course, to know more about the combination of acute and chronic lesions, to classify biopsies, mostly we ask for at least 10 glomeruli. But it goes without saying, of course, that if we have more than in diseases like, for instance, FSGS, our chances of finding the lesions increase. However, it will always be a sample out of approximately 1 million glomeruli in a kidney. And that is what we have to work with. But there are studies that actually show that with 10 glomeruli, you can make a pretty good estimate.
Right. So 10 glomeruli minimum. And how things apart the scan slides, what else has happened during the last years?
Well, the scanning of the slides is, I think, a very important development. And of course, it is related to the usage of artificial intelligence. But first of all, the scanning of the slides enables us to, for instance, share the slides with our colleagues. It is very, very easy nowadays that you can show slides simply by sharing them, for instance, in a team session with other pathologists, with the nephrologists in larger groups. So the interaction between colleagues has tremendously increased because of digital pathology. It also means that you can do a number of additional things that are a little bit more difficult on the glass slides. You can make annotations, you can measure things all quite easily. And of course, going from there is then artificial intelligence. I'm sure that it will not be long before we have algorithms by which, for instance, you not only get the scanned slides, but together with them, perhaps an estimate of the percentage of fibrosis, or what does the inflammatory infiltrate look like, which cells does it contain. And in fact, of course, what may happen eventually is that artificial intelligence, of course, will then replace the pathologist, because it starts with these measurements. But I'm sure that it will not take very long, because before artificial intelligence can also perform a diagnosis.
Oh, I was thinking that was the radiologists who were at risk due to
No,
the
we are the
artificial
second
intelligence.
one in line.
They're the second line.
Yes.
Oh, so probably I'm talking with a rare specimen, actually.
That could well be.
Right. Well, kidney biopsy is guiding the treatment strategy, and I think that the more information we have and the more precision we have in this information might help us to give optimal treatments, especially in diseases where we have a large number of new treatments, like, for example, IgA nephropathy. And therefore, I think your role might be very important in the future in order to guide us into which treatment would be the best for individual patient. Do you have any examples concerning the individualization of treatment strategies based on the biopsy?
Yeah, you now touch upon what is actually one of my favorite topics, because I think what we should realize is that the kidney biopsy has evolved from a stage where the diagnosis was the main issue. And I think that our recommendation, so to say, going from the findings in the kidney biopsy, we should realize that, for instance, a classification like lupus nephritis is still the only classification that is truly evidence-based link towards a certain therapy. For many of the other biopsies, of course, from the biopsy, we can make an estimate of, let's say, chronic changes or acute changes. We have many classification systems or systems that enable us to give a profile of the biopsy. You mentioned IgA nephropathy. Of course, there we have the MEST-C score. But at the moment, this MEST-C score is not used to say something about a therapy. And what you are saying is something that is currently happening. We see that there is a huge number of new therapies emerging. And this means that for any particular disease, at one point, of course, a choice must be made, because for a particular patient, we want the best possible outcome. And it is obvious that the best possible outcome can only be obtained if we give the patient the best possible treatment. And of course, this solution to the decision does not only lie in the biopsy, it also lies, I think, in the combination of clinical, serological features. Biomarkers are an important player here. But as a pathologist, and knowing how tremendously variable a biopsy can be from any patient, for instance, with IgA nephropathy, I would say that in the biopsy would lie an enormous source of data that should be able to guide us into these treatment decisions. But it is very interesting that actually at the moment, there are not so many studies that investigate this. And I would like to emphasize that I think this is very important. There are many studies on new therapies, new treatments in many kidney diseases. And then we read in the trial reports that, for instance, there was a histological proven diagnosis, but we do not see in the report how this influenced the outcome. So for a simple trial where you would have, let's say, two arms, for instance, you have your, let's say, basic therapy, and on top of that, you give a new one. And you either give the patient the new therapy or a placebo. First of all, of course, you would want to know, I think, whether by any chance, looking at the biopsy data, there were, for instance, more patients with a chronic disease in the one arm than in the other. That's a sort of quality control. But then, of course, more interestingly, you could investigate whether there are some lesions in the biopsy. For instance, take again IgA nephropathy. We know that some patients may have a number of crescents, whereas others don't. Could it be that this new therapy then would be specifically helpful for patients with crescents? Could it be that in the end we would have a decision based on the fact that if you have an IgA nephropathy and you have a number of crescents, then this particular therapy is giving you a very good result. Whereas perhaps for another patient with another feature like a segmental sclerotic lesion, another therapy could be given. And we are only at the beginning of finding this out. And I think that it's a shame that in many of the therapy trials, there is not a thorough investigation into all of the complexities of the biopsy. And I would really like to say from here that I would advocate this because I think it's important, and it's important for us to realize how to make choices in the very near future.
Exactly. And what you say, it makes me think that sometimes I'm reading about therapeutic protocols for various glomerular diseases, and there are no follow-up biopsies. So we are based exclusively on very basic biological outcomes, GFR, proteinuria, but we don't know if the process is still active in a morphological level, in biological level. So there is a long way to walk and a lot of bridges to create. And I think the translation from biopsy to the therapeutical practice is something that we should discuss. And from what you say, probably we have the first elements of such a fusion of ideas, or not?
Yeah, I'm currently working on studies that actually pose this question. So, for instance, we hope to come out soon with a study on lupus nephritis, where we found that a new therapy in the form of an anti-CD40 antibody was most sufficient in patients who had monocytes in their glomeruli, for instance. And that was unexpected. And it was a finding that sort of shows that a biopsy may be helpful in an unexpected way. And for this question, you don't even need a second follow-up biopsy. You may need this to pose another question. For instance, repeat renal biopsies, of course, may help us in lupus nephritis, also in ANCA vasculitis, to find out whether there is still active disease. But for this first initial decision, only the biopsy before treatment is actually necessary.
Right. So there is a long way to go to have a clinical morphological classification of diseases that might help us to adapt our strategies, and probably the coming up of a large number of new agents might incite us to do this.
Yeah,
So there is a lot of this is an exciting period for your specialty as well,
it
even if
is.
it's job
And
arrival.
to add to that, I think that we should also not underestimate how important artificial intelligence is for these kind of studies, because for the first time we are capable of sort of grasping the whole biopsy picture and turning it into a huge number of data. And artificial intelligence can handle these data and can also combine them with clinical data, serological data, biomarkers. So it's a very exciting era where we can have totally new findings that, in fact, may be changing, hopefully, the outcome of our patients with kidney diseases.
So, in my opinion, artificial intelligence will not replace you. It will just
It will.
increase significantly the efficacy of your work, our work as well. So, perfect. So, I will go now to the personal questions. And the personal questions are: if you were in a desert island, which book, luxury item, and two songs would you take with you?
Yeah, I've been thinking about that a lot, and I was able to make choice for the book. Actually, I was thinking that sometimes I go to an island during the summer holidays. It's not a deserted island, but it's a small island in the Netherlands called Vlieland. And a couple of years ago, I thoroughly enjoyed reading the book Grand Hotel Europe. It's a Dutch book from Ilya Leonard Pfeiffer. He's a Dutch author, but the book became very popular and it was translated into many languages. So I can thoroughly recommend it. It's all about tourism and how our view of the world is changing through tourism. And if I can also opt for a second book, I just want to mention that I am very much looking forward to read the book of the Nobel Prize winner of Hong Kong, who wrote The Vegetarian. You only gave me the option for two songs, and I was thinking I would go mad if I only have two songs to listen to on a deserted island. I don't know
Ingeborg,
how long you want me to stay there, but
just for you, you can add the third one if you want.
okay. Well, I just wanted to say that I love listening to music. In fact, I listen to music a lot while I'm doing my biopsy evaluations. And but here I thought, well, if there's one song that has a connection also to the topic, it's the song "Island in the Storm." It's by a singer from Los Angeles, Mia Doi Toth, and this is all about how our lives are changing through all of the modern developments. So that may be a nice song. And being very practical, I thought, well, if I can only take one luxury item, it would probably be a piece of soap.
A piece of soap, right?
Yes.
Some opted for a pillow.
That's also a very good
but
one.
you can add a second song.
A second song. Oh, well, perhaps I would take something of the Beatles. Perhaps the last one that came out. What's the title again? I forgot now. I have to look that up. The new one, which is perhaps going to have a prize.
Of Beatles.
Yes.
Okay.
Yeah, they reconstructed it.
Right. Yeah.
From an older version.
I didn't hear it. Perfect. Okay.
I think it's called Now and Then.
Now and Then.
Yes.
Perfect. Tell me about your town.
Yeah, I was thinking, so which town should I tell you about? Because I live in a village. It's called Oegstgeest, and it's a very old village in the western part of the Netherlands. It actually goes back to the Middle Ages, and then to more recent centuries. But I work, of course, in Groningen, which is in the northern part of the Netherlands. And that is really a very beautiful city. It's like Amsterdam, but then more well preserved, with canals and beautiful old buildings and old churches. And it's very near to a beautiful area, as I mentioned, near the sea, and also where we have a couple of Dutch islands. This sea is called the Waddenzee, and that's actually a protected UNESCO area. So I would invite everybody who would like to visit the Netherlands, not only to go to the places in the western part, but also come to the north and come and visit us in Groningen.
Wonderful. Perfect. So, dear colleagues, the evolution of our clinical strategies in nephrology is not possible without a solid parallel development of the renal pathology. Professor Bajema has shown us the way these two are coming together, hopefully. Other podcasts are available in known platforms. Please take care.